In this video, we present the case of a 45-year-old male with left knee medial post-meniscectomy syndrome. Indication for medial meniscal transplant was discussed with the patient. Our treatment of choice is an orthoscopic fresh frozen meniscal transplant with bone plugs. The innovations on the technique that we're presenting are several and important. First, this is an orthoscopic technique. Second, we use preloaded meniscal sutures because it allows a perfect vertical place of the stitches that incorporate the entire height of the meniscus to the capsule. Third, the use of bone plugs. This is not a new feature, but the combination of these three characteristics hasn't been reported before. At least 5 to 6 alternated colored sutures are preloaded in the body and anterior horn of the graft, and the two bone plugs, posterior and anterior, are preformed to an 8 and 7 mm diameter respectively and also secured with transosseous threads. Diagnostic arthroscopy and the preparation of a bleeding meniscal bed area are carefully performed without ischemia. The meniscus remnant is saved until the meniscus capsular zone red area is reached. Previous meniscal extrusion and integrity of the inferior meniscal capsular junction is inspected also at this point. For medial meniscal transplantation, the posterior tunnel should be placed behind the medial tubercle in front of the PCL tibial insertion site. A meniscal root tibial guide at a 45 degrees angle is introduced through the anteromedial portal, and an 8 mm retrotracted reamer is employed to prepare the posterior transtibial tunnel. Number 1 bicural transport suture is introduced through the tunnel. Next, a suture passage device is used to place a transport suture in the posterior wall remnant. Before graft placement, 2 spinal needles, number 18, are introduced in the posterior medial knee angle in an outside-in manner through the skin and the knee capsule. 2 number 1 PDS sutures are introduced through the upper and lower meniscal wall and recovered through the anteromedial portal. Definitive sutures preloaded in the bone plug and the posterior medial angle are then passed, and the meniscus is carefully introduced manually inside the knee with gentle pulling from both threads. When entering the meniscus to the joint, it is crucial to pull the graft at least from 2 separate points to allow a correct positioning and to avoid twisting. If this maneuver is predicted to become difficult, a previous pike crusting of the medial collateral ligament is advised in order to increase the space for the passage of the bone block, as this can be a very limiting step of this procedure. Once the meniscus is set conveniently, the most posterior suture already passed through the posterior meniscal rim is extracted independently and tied down from the AM portal using a knot pusher and with alternating post half hitches until it is firmly secure. A suture retriever straight forceps is the tool selected to collect all the preloaded sutures of the meniscal body and anterior horn and then suture from posterior to anterior in order to attach the graft to the joint capsule. But before suturing, the correct placement and balance of the graft must be checked, maintaining tension from the meniscal root sutures at all times. An assistant will be in charge of extracting the sutures, with special attention to do it in the right order and to do not unload any of them. Our task during this phase is to create the space with the probe in between the graft and the meniscal rim, presenting the sutures to our assistant. The next step in the surgery will be to create the anterior tibial tunnel. This tunnel can be done at the beginning of the procedure, but we rather to do it after all the body sutures are extracted because it gives us an exact idea where is it related to its anatomic location. Ideally, it should be positioned in front of the tibial insertion of the ACL and behind the intermeniscal ligament. Technically, the same steps that were used to create the posterior tunnel are repeated, with caution, as this tunnel is much shorter and very anterior. The sutures extracted from the body and the anterior aspect of the graft are then firmly attached to the capsule, with care to do not trap subcutaneous fat tissue or any terminal branch of the saphenous nerve. As these sutures are normally deep because of the swelling, a knot pusher can be very useful to do this maneuver conveniently. The posterior horn area, which has received only one suture at this point, is reinforced to the posterior capsule using all inside sutures, normally in a number of 3 or 4 of them, both in the upper and lower region of the meniscus. Finally, the sutures from the anterior and posterior horn are sutured to each other at 30 degrees of knee flexion with valgus, leaving both meniscus horns anchored and completing the transplant.